my case presentation called Uncover the Covered. So, our case is an example of how to be a doctor detective, so that you can search for the clues to solve the puzzle, to reach your final diagnosis for proper management of your patient. So we have to be detective in each step. Our case is a 40-day-old boy came to our ER with fever and persistent vomiting. He was admitted nearby his hospital as a case of gastroenteritis, and he received IV fluids. On examination, he was drowsy, dehydrated, and anterior fontanelle was depressed. So we have to ask ourselves about his history, his examination, as it was always a big differential diagnosis for a fever and persistent vomiting at this age, beginning from GIT, CNS as meningitis, intracranial hemorrhage, electrolyte disturbance, and a lot of lists. His investigation revealed just a mild anemia, CRP high with 35, and he done CSF as a routine sepsis workup, and it came out to be free. His random blood glucose was 89 with mild metabolic acidosis, pH 7.3, and bicarb is 12. He has mild renal impairment and normal liver function. So here, what is missing? Can any one of you give us the first clue as regard his examination or something missing we didn't find? The resident there missing a very important, and this is the first clue in our presentation, which is covered. He missed to be examined for his genitalia. So we have to uncover the cover so that we can find the puzzle. And this is, I hope it is clear, his external genitalia. He has something like a phallus, not a penis. There is hyperpigmentation as regard or in comparison to his size. And but it is not shown in the photo, he has only one opening underneath this phallus. So what do you think about this genitalia as regard the boy of 40 days old? Any comment? Is it a normal boy? No. Why? Did you feel or did you see any palpable testes? So we can see that the first question we have to ask ourselves, are there any palpable testes in this child or not? And actually, by making a SOAP test, there are no palpable testes. So this boy has no palpable testes, so he is considered to have an ambiguous genitalia. So he has to be referred to complete his investigations. And the most important investigations that has to be done immediately is his sodium and potassium. So his sodium is 118, his potassium is 7.1, so he has hyponatremia with hyperkalemia. So the first thing that we come to our mind with ambiguous genitalia and adrenal crisis, we have to think about congenital adrenal hyperplasia. Why? Because it is the commonest cause of ambiguous genitalia in neonates or in children whatsoever, and also it is the commonest cause of disorder of sex development, or what is called DSD. Of course, as we all know, it's an autosomal recessive disorder, so it is common in our country due to positive consanguinity. It is caused by deficiency of the enzyme that produce cortisol and aldosterone, and the most common type is 21-hydroxylase deficiency, which accounts more than 90% of the cases. This is the simplest way to know how it is the congenital adrenal hyperplasia. Of course, لو اي حد فينا بيذاكر congenital adrenal hyperplasia بالستريتوجينيسيس والكورتيزول والالدوستيرون وكميه انزيمز كتيره جدا, this is the simplest way that I find. يعني بالعربي كده ان احنا كانها حنفيه وفيها 3 انابيب. اول انبوبه بتاعت الكورتيزول, الدوستيرون and 6 steroids. Normal is TH stimulate the adrenal glands to secrete the 3, 6 او the 3 steroid precursor. If there is a deficiency in one of the enzymes that causes the cortisol pathway, so there will be deficiency of the cortisol and aldosterone with excess of the sex steroids. So the patient will come with manifestations with cortisol deficiency, aldosterone deficiency, with excess of sex steroids, which is testosterone. So the females were born is in hypervirilization, or even brother 5, which is at the same as a male. This is, of course, the 21 hydroxylase deficiency, which is the most common type. And as we all know, there are two types. The classical type, about 75% of the cases, which is salt losing, and also a small percent with a simple virilization, and a non-classical or late onset type that appears in the adolescence. It presents with a different manifestations, begin with poor feeding, vomiting, dehydration, weight loss, failure to swim, then become the manifestation of the adrenal crisis, hypotension, hypoglycemia, hyponatremia, hyperkalemia, and also metabolic acidosis. And don't forget, it may end by the adrenal crisis, which is very important and one of the life-threatening condition, because this baby, if this try to any stress or any infection, he will have to be good managed for not to be an adrenal crisis, and the stressometer comes to the red line and the zebra's line will going to be off his body. And here we have to consult a pediatric endocrinologist to make treatment of this adrenal crisis, beginning with the golden sample. We have to withdraw golden sample to do 17-hydroxyprogesterone, testosterone, cortisol, sodium, and potassium. And don't forget, if this baby comes in a shock stage, we have to do a resuscitation, as we all know, the ABC, the airway, breathing, circulation, and drugs. And of course, they are dehydrated, so we have to correct the dehydration in the form of the maintenance, deficient, and any ongoing losses. And please don't forget that all these IV flows had to be done on infusion pump. ليه؟ عشان ما يبقاش ان احنا سالوسات وبوينتس وهننقط والنيرس هتقلل الريت. لا, has to be a very cautious in the IV fluids. Of course, we have to correct the electrolyte disturbance, beginning from the hyponatremia, hyperkalemia, metabolic acidosis, and also the hypoglycemia. But the main course or the mainstay of treatment is glucocorticoid. Of course, we will begin with the stress dose, beginning from 100 to 100 milligram per meter square per day. And don't forget to treat the precipitating cause and monitor for the vital signs and the electrolytes. And here our resident thought that we have reached the diagnosis and the case is already closed. But our boy is still dehydrated, although beginning for his mineralocorticoid and glucocorticoid and oral saline solutions. And here comes my favorite proverb in endocrinology. The eyes are useless when the mind is blind. So you have to think of this disorder so that you can search for it. And this is another clue. And this is another uncovered part that we have to uncover it. So we have to uncover the facts so that we can reach the proper diagnosis. His urine output. He is always dehydrated, although he is giving good oral intake and IV fluids. So we have to think, and it's a very risky to do ask about the mother, or the mother may be not that intelligent to detect for the urine output or the presence of polyuria. So please, if you have congenital adrenal hyperplasia and polyuria, don't forget the second clue in this case, which is the congenital adrenal hyperplasia causes renal tubular acidosis type 4, hyperkalemic renal tubular acidosis. And this is very important. It is the only type that contains hyperkalemia. It's due to either to hypoaldosteronism or resistant to the aldosterone. I will not go in the details of the, can we check the time? Just 1 minute. I will not go to details of the renal tubular acidosis, but there is also just 1 minute. Okay, and this is a comparison for the types of renal tubular acidosis. As we said, the type 4 had the only type of hyperkalemia. And finally, we have to not miss the target and avoid all the pitfalls so that we can reach the proper diagnosis. My final conclusion that the careful genital examination is crucial in all children to detect any ambiguity. Don't forget that the congenital adrenal hyperplasia is the commonest cause of disorder of sex development. Adrenal crisis is a life-threatening condition, and don't forget to consult pediatric endocrinology. And the most important, and my message for today, don't forget to uncover the cupboard, which is in our case the genitalia and also the urine output. And finally, thank you.